Welcome to our presentation on preparing surgical international medical educators for immersion in Malawi. My name is Surya Pranani, and along with Karma, I'll be presenting this project. We had support from Dr. Kathleen Casey, Dr. Alexander Leader, and Leslie Toledo from PFP, Physicians for Peace. Malawi is a landlocked country in southeastern Africa and has really improved its health outcomes over the past 2 decades, but still faces a large crisis in Malawi due to dual pressures from communicable and non-communicable diseases, compounded by extreme poverty. There's a severe lack of health professionals, with only about 600 physicians for a population of 19.2 million, and that it worsens when thinking about surgeons, who number in the 50s. The public healthcare sector in Malawi is free and organized into 3 tiers. The primary tier consists of rural health centers and provide care to their respective communities by communicating with traditional healers, health surveillance assistants, and community health workers. The secondary tier includes the district hospitals that function as referral centers for the rural health centers and service populations anywhere from 140,000 to 1.4 million. The tertiary tier consists of central hospitals that include Queen Elizabeth Central Hospital and are often underfunded, understaffed, under-resourced, and overpopulated due to the high number of referrals from other tiers, coupled with socioeconomic barriers to healthcare. We developed a fundamental understanding of Malawian healthcare and statistics through the international healthcare reports from WHO and CDC, as well as scientific articles. We then reviewed historical output reports and testimonials of previous IMEs to understand the scope of the work they did and the issues they addressed, as well as their impacts on the clinical and educational metrics at Queen Elizabeth Central Hospital. We gathered information relating to the clinical settings, as well as the cultural climate and lifestyle in Malawi. And then we created a survey to collect the qualitative data on the experiences of recent IMEs. A semi-structured interview format was used to query the recent IMEs there, and future surveys will be used to evaluate the changes of the onboarding process and the comprehensive guide. Through collection of data from PubMed and surveys from PFP IMEs, we found many challenges that face providers at Queen Elizabeth Central Hospital. On the left, we see hospital-centric challenges, and on the right, we can see patient-centric barriers to healthcare access. For the hospital side, we found that there are significant challenges in staffing the hospital due to the low number of providers available. This was strongly apparent in terms of anesthesiology, which is often a cause of canceled surgical cases. This was recently addressed via educational initiatives, but is still an issue that is currently plaguing the surgical care in Malawi. We want to emphasize the low number of surgeons as well. In addition to staff, there's a lack of single-use surgical supplies in the OR, leading to providers and staff to sterilize equipment between cases, often leading to poorly functioning equipment. Hospital space is often inadequate to handle the volume of patients that are referred to Queen Elizabeth. Patient-centric barriers include financial costs, logistical challenges, and familial support. One example that commonly arose was the situation of a trauma accident where a patient who has been in a motor vehicle accident may not be able to get to the hospital due to a lack of ambulatory infrastructure. And once they're there, they're not able to stay there for very long due to financial cost of missing work, as well as a lack of familial support. PFP is guided by an operating philosophy of teach one, heal many. So there's a conscious effort to develop local capacity in a sustainable way through comprehensive training programs and strong research partnerships. In Malawi, PFP has specialized mobilized volunteer surgeons to provide hands-on surgical training, didactic training, and surgical mentorship at the Queen Elizabeth Central Hospital for a period of 3 months or more. PFP is currently involved in QECH, Queen Elizabeth, in the ways listed above. In addition, the impacts of IMEs moves beyond their role as surgeons in the operating theater. The table to the right shows a schedule on a typical week as an IME. IMEs are encouraged to work within local systems and develop relationships invested in the long-term success of the trainees in Malawi, and they also provide mentorship and actively engage the registrars with formal lectures and discussions. Our project is currently ongoing. We do have some initial conclusions from our project as we finish gathering data from PubMed and are on our final interviews with previous IMEs. We have a strong groundwork with the comprehensive resource and are working on implementing feedback from previous IMEs. The resource will include important context, schedule structure, hospital layout, and current events in Malawi, as well as educational information. We included backgrounds on the challenges of medical care in Malawi and PFP improvement targets. We hope this will improve the onboarding process for PFP. We would like to acknowledge the following people for their input and feedback: Dr. Borgstein, Dr. Abbott, Dr. Aronson, Dr. Asplund.